Thank you to the organisers for the opportunity to be here today to discuss a bit more about bone marrow transplant in metabolic disease, more specifically leukodystrophy, and our stem cell gene therapy programme at Manchester Children's Hospital. Just a brief summary of what I'm going to cover in the next 20 minutes or so. I'll talk about the principles of bone marrow transplant in metabolic disease, using Hurler syndrome as an example, before going on to discuss a bit more in detail about gene therapy and how this differs from allogeneic bone marrow transplantation. I'll use metachromatic leukodystrophy as an example, seeing as it's MLD that we have an approved stem cell gene therapy product here available on the NHS in the UK, before discussing briefly about the current evidence and licensing and our NHS real-world first-year experience of having this gene therapy product available for patients. So I'm sure many of you in this room are familiar with the process of bone marrow transplant, but just as a recap, and for those that aren't, bone marrow transplant can be either autologous, using a patient's own stem cells, harvested before receiving intensive chemotherapy or radiotherapy, and this is more commonly employed in the solid tumour setting. However, when we're talking about metabolic diseases and leukodystrophies, it's allogeneic bone marrow transplant we're referring to. And that uses donor stem cells, which can either be from an umbilical cord, a donor's peripheral blood, or bone marrow. And it's the engrafted donor leukocytes that are able to produce enzyme deficient in the patient and ultimately mitigate some of the consequences of the disease. Now, in order to enable this process to happen and for these donor stem cells to engraft, we need to condition the patient, and that can be using either chemotherapy, quite intensive chemotherapy, radiotherapy, or antibody therapy. And normally, particularly in the metabolic disease and leukodystrophy setting, it's a combination of these different elements. And the purpose of this conditioning therapy is twofold. We need to make space so that the donor stem cells can engraft. And we also need to suppress the recipient's immune system so that the patient doesn't reject the donor cells. Obviously, this process comes with significant risks. There are risks from infection, as we're getting rid of the patient's immune system in order to enable this process to happen. There are significant risks from the chemotherapy used during conditioning, as well as the risks of immune complications, such as graft versus host disease. Now, when we're looking at specifically at metabolic disease and lysosomal storage disorders, these are characterized by an abnormal buildup of toxic substances in the body's cells as a result of enzyme deficiencies. Now, transplant for metabolic storage disorders and lysosomal storage disorders uses this principle of cross-correction, whereby the lysosomal enzymes secreted by the healthy donor cells are able to cross-correct neighbouring enzyme-deficient cells. We've also heard this morning as well about microglial cells, and the engrafted donor leukocytes can travel to the brain where they differentiate into microglial cells and produce enzyme which can enter the central nervous system directly, helping to mitigate some of the neuropathological consequences of these conditions. Now, I'm going to use Hurler syndrome as an example, as that's the paradigm of successful transplant in lysosomal storage disorders. It's a rare autosomal recessive condition caused by mutations in the iduronidase gene, which results in the IDUA enzyme deficiency. And it's this pathological glycosaminoglycan accumulation throughout the peripheral organs and the central nervous system that results in the characteristic phenotype of the condition. We see there some of the coarse facial features. We can recognise that these patients often have significant bone disease, hearing loss and upper airway obstruction. They develop progressive neurological impairment and spinal cord compression. And it's this progressive neurocognitive regression that ensues, and these patients often die within the first decade of life, normally from cardiorespiratory complications. So why do we transplant Hurler syndrome? It's the donor-derived stem cells which are able to provide this endogenous source of enzyme, which can be released into the systemic circulation and locally into the somatic tissues. We also get cross-correction and can have direct enzyme delivery into the central nervous system when these cells differentiate into microglia. And this helps to reduce the neurocognitive impairment that we characteristically see in severely affected individuals. We also know that this can stabilise somatic disease manifestations, and over the last few decades we've seen significantly improved survival. We now have patients with Hurler syndrome living well into adulthood with a reasonable quality of life. And we hope that this is something that will only further improve using what we have learnt about stem cell transplantation over recent years. So what are the key messages when we're considering transplant in metabolic disease and leukodystrophies? I think it's really important to emphasise that this is really specialist medicine. It requires careful multidisciplinary team management and continuous collaboration with other specialties and allied healthcare professionals. It's really important that people understand that this is much better at preventing disease progression rather than reversing already established disease manifestations. And it's for this reason that transplant at an earlier age results in significantly better outcomes, in addition to reducing the risk associated with the procedure. I think it's also really important that we distinguish transplant outcomes from disease outcomes. I've talked about Hurler syndrome, but still allogeneic transplant is far from perfect. Even patients who are transplanted at a very young age often run into significant problems with bone issues, as well as other comorbidities for which transplant appears to be less effective. We've made a lot of progress in recent years from careful, multi-centre and collaborative analysis of the factors that separately influence each of these, and this is something that we only hope to build on into the future. Moving into the future, stem cell gene therapy may offer new hope to these individuals, and it's something that's really come into force over the last decade for patients with metabolic disease and leukodystrophy. Now, the process is outlined by this diagram here, and in contrast to the allogeneic bone marrow transplant, this is an autologous procedure in which we're using a patient's own cells. We know that these conditions are caused by mutations in single genes, and for that reason, we are able to introduce corrected versions of these genes into the patient's cells. So in order to do this, we need to harvest patient stem cells. We also take a proportion of cells which are stored in our lab, cryopreserved as a backup, just in case we run into any problems with the manufacturing. But the vast majority of stem cells that we harvest from a patient will be sent to a centralised transduction facility where they are then transduced with a lentiviral vector containing a healthy copy of the gene in question. These gene-modified cells will then go significant quality assurance run through a number of quality assurance processes. They'll be frozen at the manufacturing site and returned to our clinical site, where they are defrosted and infused into the patient at the bedside after they've undergone intensive conditioning with chemotherapy. Now, in contrast to what I described for the allogeneic process, these patients still need to be conditioned with intensive chemotherapy, but when we're talking about an autologous procedure, we don't need to suppress their immune system, and so it's not quite as intensive as a procedure as when we're talking about the allogeneic setting. Compared to allogeneic transplant, gene therapy enables us to reduce some of these allogeneic treatment toxicities. We don't see graft versus host disease because this is the patient's own cells, and because we don't need to immune suppress the patients, we have a shorter time to immune reconstitution, which, although patients are still at a significant risk of infection whilst waiting for engraftment, this time is much shorter, and so the overall risk of infection going through this procedure is reduced. The other advantage of gene therapy is that in addition to the corrected version of the gene, we're able to couple this with a specific gene promoter, which means that patients, the gene-modified stem cells are able to produce superphysiological enzyme levels within the recipients. And then I'll use metachromatic leukodystrophy as an example of how this has worked in clinical practice. So I'm sure many of you are familiar with MLD as a rare autosomal recessive neurodegenerative lysosomal storage disease. It's got an estimated birth incidence of around 1 in 40,000, and it's caused by mutations in the ARSA gene. Now, the characteristic clinical phenotype is a consequence of the accumulation of sulfatides throughout the central and peripheral nervous system, and it's this sulfatide accumulation that results in progressive demyelination, neuroinflammation, and neurodegeneration. Affected individuals may appear normal at birth and meet their early developmental milestones before this motor and cognitive deterioration ensues, with progressive loss of function resulting in early death. Now, Libmeldy is the approved stem cell gene therapy product that's approved both in Europe and the UK here and was approved in February 2022 for treatment on the NHS. And that's a stem cell gene therapy product based on autologous CD34 stem cells, which are transduced ex vivo with a lentiviral vector encoding the human ARSA gene. Now, the first evidence for the effectiveness of stem cell gene therapy for MLD was published in Science here back in 2013, and they described this specific gene therapy product in a cohort of just 3 patients, all of whom were pre-symptomatic with a late infantile form of MLD diagnosed from genetic screening, as they had symptomatic older siblings who'd been affected by the condition. And what they saw at 2 years follow-up for these 3 individuals was sustained engraftment of these gene-modified stem cells and supraphysiological enzyme levels throughout all of the hematopoietic lineages and the central and the CSF. Importantly as well, they didn't recognise any genotoxic effects from the gene-modified stem cells. We then had an ad hoc analysis of the first 9 patients treated on the phase 1/2 clinical trial published in The Lancet in 2016, which again supported this idea where we once again are seeing sustained, clinically relevant supraphysiological enzyme levels for patients treated with this product. And then last year we had the full integrated analysis of the phase 1/2 trial in a cohort of 29 patients. All of this work was done in San Raffaele Hospital in Milan. And what we saw in 26 of these 29 patients was sustained, clinically relevant benefits in cognitive and motor function as a result of receiving this gene therapy product. I think it's important that to highlight that one of the things that we learned from this trial, and which went on to inform the licensing indications, is that this gene therapy is only effective for patients who are either pre-symptomatic or in the very early stages of the disease. Unfortunately, 2 patients in the trial were found to be rapidly progressing at the time they received their stem cell infusion, and these continued to progress and ultimately succumbed to death from the condition. There was also another unrelated another sudden death in the cohort, which was deemed to be unrelated to the stem cell gene therapy product itself. And it's this trial that has informed the licensing indications for Arsa-cel or Libmeldy that we are using here today. So the trial was only done on the early onset phenotypes, so the late infantile form, which affects patients under the age of 30 months, and the early juvenile forms who are affected between the age of 30 months and 7 years. And you can see here that patients need to be either pre-symptomatic, or if they're in the early juvenile stage, they need to also maintain the ability to walk independently and be before the onset of significant cognitive decline. At the moment, because we don't have any trial evidence, the product isn't licensed for patients with the late juvenile and adult onset phenotypes, although there is a trial ongoing in Milan for patients with late juvenile disease who are in the very early symptomatic stages. Moving on now to talk about our fair share experience in the NHS treating these patients. Manchester Children's Hospital is the only UK commissioned site for Libmeldy gene therapy for MLD, and it's one of only 3 treatment centres in Europe. So we do receive all of the NHS referrals, as well as a few additional patients from overseas. And in this first year, we've had 19 patients referred for consideration of gene therapy with Libmeldy since it was approved. 17 of these were NHS patients coming from other UK centres. And all patients go through a careful multidisciplinary expert panel review involving our neurology, metabolic and neuropsychology colleagues. Now, out of these 17 patients, only 4 patients met the eligibility criteria to be treated with Livmeldi. And I think it's really important to highlight that 3 of the 4 patients had siblings who had been affected by the condition and diagnosed at a symptomatic stage where they were too late to benefit. 2 of the patients you can see here were late infantile form. These were both pre-symptomatic. And we also had 2 early juvenile patients in the early symptomatic stages of the disease. And I think it's important that we highlight here the short duration of us first hearing about these patients, from them first getting their diagnosis, to having a gene-modified stem cell product infused is less than 100 days in all but 1 patient. And actually this second patient, who took slightly longer, was ready to go but developed a severe central line infection and ended up on intensive care. So we made the conscious decision to delay her for 3 weeks, particularly as she'd been diagnosed at birth, because the family had an affected older sibling. And I think the most important message really to highlight is that the vast majority of patients referred for treatment with Livmeldi weren't eligible for treatment because their disease was too far advanced at diagnosis. You can see here that the vast majority of these were late infantile patients who were diagnosed with symptoms, and 1 patient had early juvenile disease and significant cognitive decline, which meant they didn't meet that very strict threshold to receive Livmeldi treatment. The other 2 patients actually were never eligible because they had the adult onset phenotypes. And apologies, this is a very busy table, but I think the main thing to take away is that the reason all these patients were ineligible was because their disease was too far advanced at diagnosis. So in summary, we've treated 4 eligible early onset patients out of 17 NHS referrals. So despite having this therapy available, only the majority of children, over 3/4, are ineligible at referral because their disease is too advanced. Now, we've shown, and there's lots of data from our centres and our centre and the team in Milan, that we can mobilise, leukapheresis, manufacture a product, give these children myeloablative conditioning and infuse them when they're as small as 5 kilos, which really brings us on to the question, why don't we have newborn screening available here and now when we have a treatment available? I'm sure that many of you will have seen Teddy's story when it made the headline news here in the UK a few months ago. And Teddy was the first patient treated in our centre to actually receive Livmeldi on the NHS. And I think despite the hope afforded by such treatment, obviously this was coupled by a story familiar with so many, and I'm sure familiar with many of you in the room here, in that the family were also simultaneously going through the tragic impact that this condition can have, as Teddy's older sister Nala was diagnosed at a symptomatic stage where she was ineligible for treatment and was in the progressive neurocognitive decline stage, whilst Teddy was having her gene therapy in with us. So I think, despite the hopes and successes afforded by stem cell gene therapy, and I do believe it is the future for leukodystrophies, we urgently need to implement newborn screening as soon as we have efficacious treatments available. For MLD specifically, we've got recent US and German pilot studies which have proved the concept. The US study actually demonstrated almost 100% specificity using a 2-tiered approach in which the 5-day heel prick test would be screened for sulfatides, and if they were found to be elevated, this would trigger a second test looking specifically at ARSA enzyme activity. And there's also been a similar German pilot study which has shown that this screening can be effective in a cohort of 80,000 newborns. There's been several cost-effectiveness studies, including here in the UK, when we've shown that newborn screening and actually treating these patients with gene therapy, despite the high cost of the drug, is effective. And I think it's clear that with any rare disease, as we've heard this morning, a collaborative approach is required. It's great to know that this is ongoing, particularly in the diagnostic stage and trying to find and identify genes responsible for these rare disorders. And I think we also need to take this approach when we have therapies available moving forward so that we can lobby international organisations together and really expedite the newborn screening process. Whilst these lengthy approvals are pending, how many more families are going to be forced going to be forced to endure the devastating consequences of these conditions. I've said that I believe that autologous stem cell gene therapy is the future of these conditions, particularly given that it's safer, has a reduced toxicity compared to allogeneic transplant, and enables us to manipulate the process so that patients can produce supraphysiological enzyme levels. And hopefully, as these patients grow older, we'll start to see how much more effective it is than standard allogeneic transplant. I've put here the paper for Hurler syndrome, and actually we're due to open a trial later this year here in the UK where patients are going to be randomised to receive either allogeneic transplant, which is currently the standard of care for patients with Hurler syndrome, or stem cell gene therapy. And it's this data that's going to be really helpful moving forward to help bring further gene therapies into clinical practice. Thanks to Professor Rob Wynne and all of the rest of the gene therapy MDT at Manchester Children's Hospital. Simon Jones leads the metabolic side, and I'm sure many of you know Deepak leads our neurology service. Obviously, all the international collaborators who were involved in this work, particularly the team in Milan who have pioneered and brought this stem cell gene therapy for MLD into clinical practice. Thank you all for listening, and I'll be very happy to take any questions in the Q&A at the end.